it was. We were supposed to start 40 minutes ago, but we had some major technical difficulties. You should see the setup I have right now. I have two computers here, speaker there, blah, blah. Man, I had to jerry rig the heck out of it. But we are here, needless to say, and that's what it's all about. It's all about the determination to persevere and overcome all the obstacles that come in your way and get to the desired goal. So, I use most of the time I bring on stroke survivors so that they can come on and share their testimonies, and you can grab them as pieces of inspiration and determination. And as each week goes by and you're capturing those pieces of inspiration and determination and stacking them and putting the pieces of the puzzle together on your journey, it becomes something beautiful and amazing as you continue on your journey. But today, we have a different show for you today. Today, I have brought on a neurologist, Dr. Olivo, and a neurosurgeon, Dr. Pillai. So, we're going to be discussing a range of topics, starting from, uh, ranging from AVMs to aneurysms to strokes to neuroplasticity. And I urge you to, go ahead and jump on the chat and ask any questions that you want to ask. So, you know, hey, Brad, what's up, brother? How's it going, man? And yeah, so, you know, if we had some of these doctors on here, I would go ahead and bring them up, but they kind of are doing their own thing right now. But so I'm just gonna have to jingle along right now. So, anyways, hey Brad, what's up? Hey Salud, thanks for joining me, man. Like I was saying, we had a heck of a morning this morning. We were supposed to start at 9 o'clock this morning. We even jumped on, and man, I don't even know what the heck was going on. My freaking microphone, they couldn't hear me. I was trying to do all this crazy stuff, and yeah, I don't know what happened, but yeah, it was ridiculous. We ended up having to log on with an iPad, and so yeah, that's where you guys are seeing me from, is from my laptop, but you're hearing me from the iPad. Yeah, ridiculous, I know. But you gotta love technology. Technology is great until something goes wrong and you don't know how to fix it. I think that's one of the aspects that you know makes technology great. You can, if you know how to fix it, hey, you're in the money, right? You are in the money. So, Salute. How's Tom doing? Tom or Salute, let us know in the comments how Tom is doing. Are we good, Dr. Pillai? All right, we are good. Well, without further ado, we're gonna switch it up a little bit. Uh, there you go, Salute. Technology, go with the flow and keep going. You gotta stay determined and keep the show a rolling, man. We weren't able to get on when we wanted to, but we gotta keep it in order, or it's gonna come out all wacky. So here is Dr. Olivo's couch and office. But without further ado, here is Dr. Pillai. Hey, Dr. Pillai, how are you doing?
Good morning. How are you guys?
Hey, man. Thank you so much. First of all, I
Thank
want to
you.
say
Yeah, thank
thank
you
you
for having
so
me.
much. Yeah, thank you so much for coming on the Determined Show. I appreciate it. I really do. Um, thank you. So why don't we start out with just, telling the audience, who you are.
Okay. Okay. Good morning, everyone. Thanks, Mark, for allowing me to do this with you. I'm Dr. Pillai, one of the neurosurgeons from Loma Linda University. I'm a cerebrovascular neurosurgeon who uh, does endovascular treatment as well. So I'm a dual trained neurosurgeon who does open vascular surgeries as well as endovascular surgery. I work closely with Dr. Olivo. He's a neurologist, so I take care of some of his patients who has issues who need to be treated either by open surgeries or endovascular surgeries. I was trained.
There you
I'm
go.
originally
No,
from. Yeah, go ahead.
no, go ahead.
I was just telling my
All right.
background. I'm
All right.
from. Yeah.
What's your background? Let's hear it. I would
Yeah,
love to.
I mean, my training is part of my training was in India, and then I did further training back here in US. My training was mostly in Ohio State University, and then my fellowship training was also in the same place. So then I moved to Loma Linda.
Nice. So you're here at Loma Linda. Which Loma Linda are you
I'm
out
at
of?
the main Loma Linda hospital. Yeah.
Okay. Nice, nice. So I just want to maybe dig a little bit deeper. Did uh, did you always know that you wanted to be a doctor?
You know, not really. I mean, I think when you're growing up, we get all kind of things go through your mind, right? So you keep changing. Sometimes you want to be a teacher, sometimes you want to be a scientist, and part of my my career selection. I think it's my parents actually influenced me a lot because my mom was very kind of pushing me to be a doctor, to
Yeah.
even when I was young. And then we started learning about medicine, and we see doctors when you go to the clinic, and you see that and then slowly get into your mind. But I think, yeah, when I finished in my high school, I kind of, um, I know that I want to become a doctor. So
Yeah. And then how long? So, obviously being a surgeon is a huge deal. And being a neurosurgeon, I would assume working with the brain is even, one that is, for lack of a better term, a bigger deal. So what is the amount of schooling that goes into that? Like, how long is it?
it's a pretty long,
Yeah.
very long. I mean, especially for a surgical specialty, it takes very long. For me, I mean, it's actually much longer because I did two training. One training was in India, then I have to redo the whole training, pretty much the whole training here. So mine was really longer than expected. But even in a regular pathway, your training will be pretty long. So you have 4 years of medical school, right? And then you do most of the time you have to do an internship, which will be an year of internship, and then another 6 years of 7 years of neurosurgery training,
Wow.
and then you do a fellowship, which will be most of the time will be 1 or 2 years.
Oh,
So that
wow.
yeah. I mean, it's medicine is an evolved. I mean, even today, I mean, we learn. I mean, it's not like you're not stopping it. So
Hmm.
you learn every day, something new,
Yeah.
and you have to update yourself. You can't just because back the medicine is such an evolving field. You have to keep update with your skills and your training. Otherwise, you will not be able to do the things you want to do.
Yeah.
And even even for the things you're talking about, AVMs treatment, right? It's
Well,
changed. Right.
let's not jump into that yet. Dr. Levo is in the house, so we're gonna learn a little bit about Dr. Olivo real quick as well. Just we're gonna ask him the same thing. I'm gonna drop you down and then I'm gonna bring you back up just so we stay with the flow of just so we stay with the flow of how it's set up here. There we go. Dr. Olivo, how's it going, man?
I'm doing okay. Thank you for having me on again. It's Dr. Pillai.
Yeah, Dr. Pillai. So we got a bunch of brain fanatics up in the house today. Hey, so I was asking Dr. Pillai, you know, how he decided or how he knew that it was his destiny to, you know, be in the field that he is, and you know, to go ahead and be a neurosurgeon. So I want to know the same thing about you, Dr. Lee. I don't know if we discussed it already, but you know, when did you know that, hey, you know what, I'm going to be the world's greatest neurologist? When was that? When was that a factor that came into your mind?
Well, I think it was inherited early on, that I wanted to be just a physician and help people and heal people and take care of people since I was like 7 or 8 years old.
Wow.
Really early on.
Wow.
That was my niche. Obviously, you know, I came from not the most optimal situation or a silver spoon platter given to you to get into the field of medicine. So it was quite a challenge because I didn't have that mentorship to get into medicine early on. And then once I got into medical school, that's when I really found out that I wanted to be a neurologist. And the main reason for neurology was, one is the complexities, and it's kind of like figuring out a puzzle. And then you're responsible of trying to figure out that puzzle. And once you figure that puzzle out, and you make it better, and you improve the situation. And then the whole person, right, regarding that puzzle. And so that what really inspired me when it came to neurology. It's quite challenging. Not every person is the same. Not every case is the same. Not every outcome is the same. And it's very, very difficult. And I needed something to keep me challenged. At the same token, my wife also inspired me to become a neurologist. My wife's my better half, and she's also a neurologist. She specialized in movement disorders, but she actually decided to become a neurologist before me. So she says that I followed her. I originally thought I was going to be an endocrinologist because I liked the hormonal changes and the pathways. And then I got introduced to neurology. Then I did a rotation through when I did the fifth pathway at Mount Sinai, was one of the neurologists there. And it really inspired me that this was really what I wanted to do. And so from there forth, I really buckled down, and every mentor I've had along the way during residency and fellowship has really helped propel me to go that direction and to further and to kind of spread my wings within neurology and outside of neurology, and meet great colleagues such as Dr. Pillai that's helped several of my patients. So I've been very blessed and fortunate during my journey.
Yeah, awesome. So yeah, so you're saying how, so basically I kind of want to know exactly how it works then. So say for instance, you know, I go in, I say, Dr. Levo, I'm having crazy migraines, you know, what's going on? So how does it work going from a neurologist then going to a neurosurgeon? How does that happen?
Okay, it happens very often. Actually, we're discussing cases actually before we came in live, because sometimes when we're working up patients, when it comes from migraines or headaches, we try to find out what the underlying reason is. We don't all the time assume that these are migraine headaches. We try to classify what type of headaches they are, and say if this is a headache happening in a 9-year-old or a 50-year-old that's new onset of headache and it's progressively getting worse. And then I scan their brain and it happens to be a tumor. And that's where my colleagues in neurosurgery get involved, and they really help the surgical aspect when it comes to their treatment plan. Dr. Pillai, he's a super neurosurgeon that does interventional neurosurgery as well, where he will just cut open the brain and take out a resection, while also intravascularly coming up the pathway in the arteries could actually fix up things and do some, all different types of things. He has so many tricks up his sleeve nowadays. And it's, like he said, it's continuing to expand. So when it comes to stroke care, AVM care, surgery resections, all these things, someone with Dr. Pillai's skill set is very much needed when it comes to that comprehensive care model.
Yeah. So let's say, for instance, I come in, I say, Dr. Olivo, I'm having, the migraines. You figure out through an MRI CAT scan that it's, like you said, it's a tumor of some sort. It's small enough. Through the CAT scan, you figure out, okay, it needs some sort of surgery. So then you would refer it to Dr. Pillai. That's how the process works, right?
Yeah, that's very similar. One is we as neurologists, we looked at the brain MRI. We try to, based on imaging, symptoms, and localization, we try to figure out what type of tumor it is before actually a neurosurgeon even goes in there half the time. Is this a tumor that is non-malignant? That's what we call benign, meaning that's non-cancerous, that we can follow up with serial imaging that's not in a vital or crucial location? Or is this something that needs to be expedited and I need to get on the phone and talk to Dr. Pillai? Can you please see this patient? Or another neurosurgeon that does cranial base surgery, for example, that's impinging on some of the crucial arteries. So that's how we work together to give optimal care within the patient. Or it could be at the same time, we'll obviously control the headache or the pain aspect to it as well, the symptomology of it. But when it comes to the overall care, we have to look at the global picture of where is that headache coming from and making sure we classify it as the appropriate type of headache.
Mm-hmm. So, Dr. Pillai, you get the prognosis that Dr. Olivo sends over to you and whatnot. You look at his prognosis, you look at the CAT scans, the MRIs, and then you see what he sees. Mm-hmm. And let's say, for instance, it is a tumor of some sort. Now, if the tumor is, what size does it have to be to operate on? And is there a certain size that it can be to where you can use some form of, like, I don't know if they still use radiation or if they do.
Yeah. So I think
to shrink it.
Yeah. So there's a lot of multiple facts come into picture before we make those kind of decisions. First of all, when Dr. Olivo sent a patient to me with that kind of, he did a workup for example, he did it for headache and then found a lesion, right? So the most important thing for us to decide is that if this one is symptomatic, or is it something we saw, we call incidentally. I mean, we often see that kind of things, right? We don't have to treat every lesions in the brain. We want to make sure there are a couple of things we need to decide whether this one what we see on the scan it's causing a symptom for you or is likely to cause a symptom in you. That's one thing, right? And if it is causing symptom or is going to cause a problem, then we need to know what it is. So that's one aspect of the treatment. And the second thing is that how you're going to treat it. So there's not. So that's why there is the management depends on all these factors, right? And then once we know that this has to be treated, what's the safest way to treat it? Is this treatment is going to make more problem for the patient, or is the benefits of surgery or a treatment is going to outweigh the risk of any kind of complication from the or the natural history of the disease or the natural history of the tumor? So that's how we make the decisions on it. There is no real size. We can say this particular size is because there are certain locations of the brain, even a millimeter, a few millimeter lesion can be devastating. At the same time, there are areas of the brain, even a larger lesion may not be causing a major problem. So it doesn't really, we can't just give a one, but I mean, again, depends on several other factors. I mean, it also the patient's general health also comes into play. And there are certain workups we have to do. As I said, we have to find out what kind of tumor it is. Once we know this is symptomatic, or like, we may have to look for primarily tumors, we can say tumors coming within the brain versus coming from an outside source. So that's one we call the primary tumors versus secondary tumors. So the primary tumors are tumors coming from the primary cells of the brain or the layers of the brain. Then you have secondary tumors, which can come from outside source, particularly in older patients, like when it comes from the lung, or the prostate, or breast, or the GIT, and those kind of things. So those are the broad categories we talk about tumors. So sometimes it's easy to find on an imaging study to find out. Sometimes it's easy to say that it's primary, and there are some features we can say secondary. But always we have to, especially an older patient comes with a brain tumor, we wanted to always keep that possibility in mind, because that will change the whole treatment pattern. Because you know, and so that gives an idea about what particular type of tumor we are dealing with, it right? And as I said, anytime when you treat a tumor, one of the major component of that treatment is to find out what type of tumor it is. Um, to So how do you do that? The only definitive way of finding out is to take a piece of the tissue. So that's what the brain surgery comes in. But as I said, if you have a brain tumor coming from an outside source, you don't have to go into the brain. You can always we can approach the tumor outside and then find, that will give you an idea about the tumor in the brain. So that way we can safely get the diagnosis without going into the brain. So that's why, it takes a lot of, that's the place we may even involve an oncologist. We may discuss this, his patient's scenario in a tumor board. We do sometimes you have to do a multiple workups like metastatic workup in other parts of the brain to see if there is anything else going on. And we have to look at patient general conditions, how safe this will be a surgery if it is something you have to plan. Yeah, I don't know if I'm addressed it.
No.
Yeah.
That's perfect.
So it's not black and white as what size, whatnot. A lot of detail goes in. It could be a very small tumor, and we have to be very specific and figure out where it's coming from, what symptoms are happening. And like Dr. Pillai, if it's primary, it's coming originally from the brain, or if it's secondary, coming from somewhere else, it kind of dictates the way. And then the tumor board that he described, that's really a multidisciplinary where you have oncologists and surgeons and epilepsy specialists and all these different radiologists. Everybody comes together and tackles what's the best approach to best help the patient. And those are the things behind the scene that sometimes patients don't see. That all the hours and looking at imaging and re-imaging, and Dr. Pillai might do some interventional imaging to figure out some cases. So there's all different ways that you could approach it, and it's not. I always say neurology, neurosurgery is not black and white. It's all shades of gray.
Yeah.
And we try to do our best. We're not perfect. We try to do our best for the patient based on the knowledge that we have.
Yeah. My philosophy, or I mean, the philosophy of any treatment in this kind of situation is we want to be ahead of the natural history of the disease, right? the natural history of the disease is not going to be the worse than what I'm going to do it. So we are not going to do anything for that patient. That's why often when you do the workup, especially with the new era of getting scans for we over sometimes we may have to be more um, you know you see patients with incidental findings. So incidental findings of tumors in the brain, which may not be treated at all. Sometimes you can just watch them. You don't need to touch them. You don't have to do anything. So that's it's just not black and white. So there are
Yeah.
certain lot of things come in the picture before we make the decision. Yeah.
Are you reading my mind or what? Because I was gonna be like, one of my next questions was, so you find a tumor, you can just essentially you can just leave it, leave it in there, just watch it, just make sure that so what are you watching, like, to make sure it's not growing, to make sure it's not, if it does grow, to make sure it's not putting pressure on certain parts of the brain
Right.
that will affect,
Yeah. So this is the place we discuss with the patient about it. So you know, so when you say watching, there is a risk with that too, right? Because when you say, especially when you don't know what it is. So that's why we will talk to the patient in detail. What are the drawbacks of watching versus drawbacks of surgery or any kind of intervention? At the same time, it's a one-time imaging study. The neurologist did an outpatient, right? We had one picture and one time. We are seeing this one on one phase of the disease. So we don't know what the progression is going to be. So this tumor could explode into it could be a 5 millimeter tumor. It could explode into a 2 centimeter tumor within 6 months, versus it could stay the same way unless you know what's the pathology. So there is a downside of that. At the same time, sometimes imaging studies will help us finding out, there are certain features we can say this tumor could be aggressive versus benign. So that's why we always recommend having a follow-up study within 3 to 6 months. So that way we have a two studies in the time frame, which will give us an idea about what the progress is going to be. So if the tumor is going to stay within the same dimension within the 6 months, then gives much more confidence saying that, okay, this is something I could watch it. Whereas this tumor is growing in that particular time, then I'm saying, yes, this is not going to, behave the way we wanted. This is something we may have to take care of right now. I mean, yeah. So that's how we do it. So that's the importance of close follow up. We can't lose that patient. We can't leave the patient at that point and then say nothing to be done. So we always bring the patient within that time frame to have kind of a idea what's going on with that tumor. Yeah, makes sense.
yeah.
Okay.
And sometimes a tumor, or do an image and it might look like a tumor and it's really something else.
Right.
That's a tricky part. We have cases of we call tumor factor MS. We have different vascular malformations that end up happening, and they're not true tumors. So it's really important that we do the appropriate steps to significantly improve the outcome by giving an appropriate diagnosis.
Right.
Now, is there like such thing as the tumor being in a spot where it's too difficult to operate because of the spot of the brain that it's in?
Yeah. So that's what we were talked about. So we always look at the treatment or interventions, the risk of intervention versus the actual disease causing a problem. So if the intervention is safer than the actual natural history of the disease, then we'll go that route, right?
Yeah.
But there are certain situations it's not possible. Like some critical area of the brain, my surgery is invariably going to be worse than the actual outcome of the disease. So that's a place we do the other options where you have this focused radiation or radiation treatment or those kind of things. Sometimes surgery can be helpful in the sense that we could take a small piece of the tumor without causing it. So that's called like a minimal keyhole surgery where you can go in, take a piece of tissue at the same time, not damaging, not hurting anything, But the purpose of the surgery is basically to get a tissue diagnosis so we can further treat and further provide the treatment. Those are the places you come in with chemotherapies or radiation treatment. Nowadays we have options like radio frequency listening, laser treatment. Those kind of minimally invasive treatments can be done without doing a major open surgery.
Very, very informative. I like it. Do you have any, before we move on to the next topic, anything else to say about tumors, Dr. Levo, Dr. Pillai, any other information that you feel like the stroke community should know?
Well, we could have a dissertation, a long discussion on these, on just tumors in itself, or on just
Right.
one specific type of tumor.
Right.
But I think the caveat is trying to figure out where is it from, what it is, and what's the best approach by having the best team appropriate for the tumor. It's very important. The team is very important, and also vice versa. I think communication with the patient and letting them know what we're doing on our end to try to figure it out. Because sometimes it's difficult when a patient understands and hears that they got a tumor in their brain, whether it's a benign meningioma. It sounds devastating. It feels devastating for them. So sometimes we have to do our best to relate that to the patient, that we're doing everything for our best ability. That's why I always appreciate this show, because I always listen to the patient's perspective of what they're going through, and it gives me more reinforcement and tools to help better communicate different things to my patient. But we could go on and on about one specific type of tumor on these cases, and it's very complex, and that's why Dr. Pillai went forever in schooling, and is still schooling, and doing learning stuff on a daily basis, is because it is that complex, and there's so many different variations out there.
The one thing about when you say, I know it's kind of a scary term, brain tumor, right? But the brain tumor is like the whole spectrum of disease. There could be a tumor which is completely benign, and if it is safely treated, that patient is completely tumor free for the entire life. And there are tumors which are really deadly, and they, even with the best treatment we have, the outcomes are really bad. I mean, so there is a whole spectrum of brain tumor. So when for a layman, when you say brain tumor, always feel that, oh, this is bad. Actually that's not true. So that's something I think that's something you should be. Again, it all depends on what type of tumor. I think that's what is most of the time, that's what is going to determine, and the location of the tumor.
There's multiple people that die in their older ages that die and have a brain tumor and was never diagnosed with a brain tumor that was benign.
Right.
So just keep that in mind. So there's a saying that I don't want to do an MRI of my own brain, because I don't want to worry about stuff that really has no significance. So we don't treat the image, we treat the person, basically.
Right.
There you go. So, I mean, historically speaking, just not off your research, but maybe, or not off of research, maybe off of your own personal experiences, what are the symptoms of someone that does have a tumor, like headaches, migraines, seizures? You know what I mean?
So, typically when we see a tumor and it becomes symptomatic, there's a slow progression, and sometimes that can present as a headache. Sometimes it could present as a focal neurological deficit that causes it compress something within their brain, causing weakness on one side of their body, vision loss, etc. Another presentation is seizures. Any disruptions of our cortical networks can cause seizures, and That's another manifestation, and there's obviously a lot of other types of presentations that are a little bit more rare, but those are the most common ones that kind of when they go to the ER or they're coming up with their primary clinic and they're continuing to have headaches and headaches and headaches, and we call them red flags and headaches. You know, someone above the age of 50 that having chronic progressive headaches, having any type of focal neurological deficits, changes on their examinations, those type of things can signal that this is potentially a brain tumor, and then that's when we get imaging and neurodiagnostics involved.
Interesting. All right, so now let's shift to AVMs. I want to say AVMs and aneurysms, but they're completely different. If you want to talk about them both at the same time, it's up to you. I'm not a medical professional. I don't know if they can be talked about at the same time. I don't know. But I do know is you're born with an AVM. You're not born with an aneurysm. So I will give you the floor. Well, either one. Take it away.
Yeah. I think you want to start, Olivo?
No, go ahead. Go ahead. This is Dr. Pillai's cup of tea here. He's one of the experts when it comes to treatments and pioneers and doing the new new procedures. Well, your cat. So I'll let Dr. Pillai go ahead.
Yeah, so I think you're right. AVM and aneurysms, they're two monsters, but they have two different family. AVMs are you born with AVMs, right? So you had it when you were born, whereas aneurysms happen from two sources. One, you have some kind of baseline, like genetic predisposition for that. I mean, I would say it's 50-50 kind of thing. Your lifestyle, and then you have something happening from your blood vessels are, some risk factors for that. So both together comes to form the aneurysm. That's why if you look at the aneurysms, they usually present late in life, whereas AVM patients are mostly young, healthy patients, like what Mark was talking about earlier. Younger adolescent or early younger age group. That's the typical presentation time. So they two different pathologies and two different treatment. This is what I typically tell my patients in the clinic. So I would say this is the kind of we call it tangle of blood vessels in the brain, which was formed at the time of birth, and which is basically what's happening is that the arteries, which is pump blood from the heart to the brain, and the veins take the blood out from the brain back to the heart. That's what arteries and vein for known for. In the AVM, so you have a tangle of blood vessels within the brain, but the arteries are connected to that tissue and then directly goes back to the vein. So it's kind of a shunting. We call it a shunting of blood supply, blood from the artery to the vein through that tangle of blood vessels. And the nature has a very, very beautiful way of having this blood supply to the brain or any part of your body. So the arteries, typically if you say it's the house of, the blood comes through it, I would say, when you say the pressure head in that, it's an average is somewhere between 120 millimeters of mercury. And then it breaks into smaller tubes. Then it further breaks into very, very small tubes, which we call the capillaries, which is tiny, tiny tubes. And by the time you reach that point, the pressure head drops significantly to almost single digits, and then those capillaries gives all the blood supply to the tissue and take the blood back. then goes into the vein. So the veins are the bigger tubes which basically would bring that blood back to the heart. So if you look at the pressure head at the artery versus the vein, I was talking about the pressure in the arteries are like in 120s, whereas in the vein it goes down to somewhere around 8 to 12. So that's the difference. From the 120 millimeter of mercury, it goes all the way down to single digit. So that's a normal circulation. In what happens in AVM is that whole circulation is gone. So all the capillaries and the small arteries and the venules and the big veins, all those things are the natural pathways completely gone. Instead, you have a dysplastic, tangle of blood vessels with no real function, and it directly connects to a vein. So this 120, the high blood pressure in the artery is almost directly pass on to the vein. So veins are not used to that kind of because veins, in a normal body, the veins are not used to that kind of pressure head. So that's a whole problem with that, right? So that's why the AVMs, when they pass through this kind of high blood pressure, they tend to bleed. So that's what causes your hemorrhagic stroke. There are other symptoms too with AVMs, but the most dreaded complications or more dreaded risk of AVMs are the bleeding from the AVM. But it can also cause, because it's a dysplastic, non-functioning tissue, there could be a small part of the brain which could be non-functional too. That can trigger seizure phenomena, so which can cause seizures. So that's another common symptomatology from AVM. Again, the pattern of seizures can be different depending on the location of the AVM. And second, the third symptom, which is actually not very common, but it can be possible. Just remember the AVM, as I said, you have normal brain tissue, normal blood supply, and then you have an AVM. Can you hear me?
Yeah, I can hear you.
Okay, so the AVM, AVM is drawing all this blood because anytime you have there is no resistance in the blood circulation, the blood prefers to go to a place where you have a shunt. So if you have a normal blood vessel and AVM will take the majority of the blood, draw back into the AVM, and then put it back to the vein. So what happens over a period of time, it happens right from your birth. So the blood supply to normal brain is kind of dragged into the AVM because the resistance is low. So the normal brain is not getting enough blood.
What age group do we see AVMs in, and what age groups do you see?
Presentation wise, it's usually they don't typically present in the early age group unless it's a different way of presentation. Like if you have a big AVM with all the pumping of blood going through it, because it is circumventing the normal circulations, all going through the AVM. We call the short circuit. So the blood is going through the short circuit, going back to the heart. So if it is happening in a high volume fistula or shunting, the heart can fail because heart can't pump that blood all the time, because instead of going through a normal channel, it is short circuiting to that AVM. Sometimes that can come with cardiac failure or heart failure because heart cannot do that. That's the only time you see it in a younger patients or a young child. Whereas most of the AVMs present in an adolescent or a late childhood or even in a younger adult. So typically that's a typical age group of presentation.
I believe it's 1% of all the population that AVMs can be present. When it comes to the brain, though, it's a very specific area when it comes to where the symptoms are. Where do AVMs usually live in the brain?
So the brain has different parts, and majority of the brain is in the front part. We call the supratentorial brain, which is the major part of the brain, right? it's all over the place in the brain, but because just the fact that the majority of the brain is in your supratentorial brain, the lobar, we call the frontal, parietal, and the occipital and temporal lobe. So that's a majority of your brain. Posterior part of the brain is very small, the infratentorial. So just mere fact of the distribution of the brain tissue itself. So majority of the AVMs happens in the supratentorial brain. Again, when you look at the different lobes, again, because of the mere size of the frontal lobe, you'll be able, you may have more AVMs in the frontal lobe. Yes.
And Mark, oh, we lost his audio.
We lost you.
it's. I guess we're gonna have him on mute a little bit. How he figures this out. We're gonna watch you. Okay. so I'll kind of lead the discussion on AVMs a little bit for Mark. Mark's. Do you mind me talking about your AVM, Mark? Okay. So Mark, as we all know, has set up this beautiful show talking about being determined and recovering from brain injuries, strokes, etc. And he has his own personal story where he had an AVM at an early age, and his presentation was actually focal seizures. And so he had intervention done as well, and then had complications of epilepsy afterwards. Epilepsy affects about 10% of AVMs as a complication, or as an initial presentation was a seizure. Obviously, the difference between a seizure and epilepsy is a seizure is just having one seizure, and that could be seen in epilepsy, but epilepsy means recurrence, or having the risk of having recurrent seizures. And so that is a potential risk of the AVM. When it comes to treatments for AVM, say I had someone come into the emergency department and presented with a seizure like Mark did, and we diagnosed the AVM based on neurovascular imaging. And I said, let's transfer to the mother hub and let Dr. Pillai do his magic. What do you do right after that when the patient gets transferred or helicoptered to the tertiary care center or for care? What's the next steps?
So let me ask you again. So what was the symptom here?
So the symptoms was seizures. Obviously, the seizures were taken care of at the hospital. Let's put a scenario: seizures were taken care of at the hospital. Blood pressures were managed very well, and then the patient was transferred for possible intervention for AVM.
Yeah. I mean that's actually very important in the sense that when the patient comes with a seizure, it's a different way of, at least we have a different way of approaching that versus when the patient comes with a bleed, because bleed is a hemorrhagic stroke. So you don't have to. There is always a room to discuss options. There is room for workup, all those things. Whereas when you have patient comes to you with a bleed, it's a bleed, it's a stroke. Then it's a whole different scenario. We have to deal with two things. We have to deal with the hemorrhage, and then we have to deal with the AVM itself. So there could be a lot of uncertainties and urgency in treating those kind of situations. Whereas when patient comes with seizures, it's a different thing. Again, when you deal with AVM, again, in the era of imaging studies, patients get imaging studies all the time for different reasons. I see patients comes to me have an AVM for workup for a trauma, or some other, or ENT bleed, or a sinus infection and things like that. It could be completely incidental, but that's why it's important to designate your AVM symptomatic versus asymptomatic AVM. Dr. Olivo's patient is symptomatic AVM because he came with a symptom, which is so So most important thing for me is that I want to see the seizure is coming from this AVM area. So if that is the case, then I have to say this is a symptomatic AVM. That changes the management. So that makes whole lot of difference in my approach to that patient. So any symptomatic patients, we want to treat them, because so we know that that patient is likely to cause problems. Either one, the seizure can be uncontrolled. It can go, can be not responding to your treatment medications. Second thing is that this can progress into one of those other complications like hemorrhagic complications. So the both way, any patient with the symptoms, I tend to offer treatments. So the workup from that onwards, there are a couple of things we do. One, sometimes I may ask Dr. Olivo to get an EEG to see the seizure pattern is coming from the AVM, which will, confirm that it's symptomatic. Second thing is that we may do further imaging studies. The gold standard for any vascular anomalies in the brain to have better understanding is a catheter angiogram. I don't know if you probably know that. What we do the catheter angiogram is you take a small tube, either through a groin or through an arm. You take one of the blood vessels, take it through the highway of the blood circulation, which is through the aorta, take it to the neck. Instead of going to the heart, you just take it back to the neck, and then select the blood vessels in the brain, and then inject the contrast, and then you take X-ray pictures of the contrast. So when we do that, it just all the blood vessels will light up, and you get a picture of your X-ray picture of your brain, just showing the blood vessels. It's also a good study. It's a dynamic study, so we are going through the sequence of the activities happening in the brain, so we can see the arteries fill up. In a normal blood circulation, you see the arteries first, you see the capillaries, and then you see the veins, and then finally goes back to the major sinuses. Right? That's a normal thing. But AVM, as we talked about it, it's a shunting. So the dysplastic tangle of blood vessels show up pretty early, and then you see an early venous phase even before the normal veins are opened up. So that's what the shuntings happen. So that's how the AVM is diagnosed. And then, when you have a diagnosis, we want to see the certain other things. You want to see the location of the AVM. You want to see what's the type of blood supply to the AVM, how many arteries are going in, what type of blood vessels, is it coming from different segments of the blood vessels? And then what is the venous outflow? What's the vein? And what's the size of the AVM? And then there are certain other things we look at because of this. You remember, this is, you just remember a pipe going with this high blood circle of the water going through the pipe. Pipe cannot withstand that kind of a pressure. So what happens is sometimes these pipes can make defects or blisters, or what we call aneurysms can happen in those pipes. It can happen in the feeding arteries, or it can even happen within the nidus, within the tangle of blood vessels. Sometimes we can see those blisters within the veins. So those are very important factors we look at it, because those things are weaker parts of this whole structure, those blisters. So they are pretty much the same thing what we're talking about, the brain aneurysms, right? So they are weak parts of the anomaly, and they are more likely to bleed. Especially if you had a prior bleed, that's a very significant aspect which we need to be dealt with. And in fact, we may have to treat them even before actual treatment of the AVM. And then, after that angiogram, there are certain other imaging studies also sometimes we do, especially with MRI. We could do functional MRI. So what if functional MRI does it? We can do MRI pictures with patients doing some kind of activities, like either speaking or motor functions, sensory functions. Yeah, so that will light up the part of the brain, which gives you an idea about the relationship of the AVM to those functional areas of the brain. again, that will help us finding out what's the safest treatment for this patient. And other things we do with MRI is there are a lot of new sequences coming up in MRI where we can actually see the fibers of the brain. We call the tractography. So we can see the entire tracts within the brain, which will really help us to see the relationship with those tracts, especially the deeper tracts in relation to the AVM. That will navigating through the AVM while we do the surgery, because we want to make sure that for left side, right? So your fiber from the brain tissue, which goes through the brain, the deeper part of the brain, the AVM may be very close to it. And we can't see it on a normal MRI, whereas the tractography can clearly visualize that tracks in relation to the AVM. So when we go in with your surgery, we can be careful when you're dealing with that part of the AVM. And so that the major workup we do with AVM as such, and obviously we wanted to get medical aspects too. We want to make sure the patient is safe to go through any kind of a major surgical procedures. I mean, luckily those patients are younger, healthier patients, so you don't have to worry about it. But generally, we have to do that kind of workup too. Yes.
Not every case goes according to plan, right?
Right.
So what complications can happen when doing some type of procedure to help out the AVM?
Yeah. So that this is before we make before we make any kind of decision making about a definitive treatment of AVM, the angiography is the only invasive test, I would say, which can have complications. The MRI obviously doesn't have many complications, but before you even go into treatment, this is the only invasive test I will talk about, the DSA, the catheter angiogram. Catheter angiograms are relatively a risk, smaller risk. Again, difficult to give a number. Typically we say about 1 or 2%, like 1 or 2 patients out of 100 patients can have complication from the angiography itself, just an angiography. The complications, most of the complications are, as I said, we are going through the groin, right? We are taking a catheter through the groin into the heart. So we could injure the blood vessels in the groin. We could cause a hematoma. We could damage the blood vessels in major blood vessels. We are going through it. We could cause a stroke. We could cause a bleed in the brain. But they are very, very small. It's one. Generally, we say not more than 1 to 2 per 100 cases. So after that workup, then we go with the treatment options. Treatment options, I generally give 3 different options for patients. 1, no treatment, conservative management. If the patient had only seizures, the seizures are well controlled, that's an option. I would say, see, this is an option, but there is the advantage of that option is that no surgery, no risk of treatment. You don't have to be in the hospital. There's no surgical recovery time. You're back to what you're doing. What is the downside of it? 1, the seizure could be uncontrolled. The seizure may not be responding to medication later in life. That's one possibility. There is a side effect of medications too, second thing. And the third thing, which is much more critical, is the risk of bleeding. So the risk of bleeding, as I said, like for example, this patient came in mid-20s. This patient had AVM for 25 years or 26 years of his life, never had any symptoms, never had a bleed. So then he may ask you, what's my risk of bleeding in the next 60 years or 70 years of, depending on his life expectancy. So that's the place you have to talk about the natural history of the AVM. We tend to extrapolate the information from the literature and other patients, and this is what we tend to say. So it also depends on the age of the patient, right? So if you have a 16-year-old patient with an AVM versus a patient comes to your clinic at age of 80 or 76, So there's two different patients and two different natural history. So 76-year-old patient never had a bleed, comes with his AVM versus a 16-year-old with coming with a seizure. So there's two different patients and two different approach we are going to take. So that's why the natural history is important, and is typically the risk is about 1%. Some literature say up to 2, but generally I would say it's a 1%. So the risk I usually put it, I mean, by generally it's a very easy way to taste 106 minus the age. That's a cumulative risk of bleeding. For example, you have a 16-year-old patient comes to you with AVM, your cumulative your lifetime risk of bleeding is 106 minus 16. It's 90%. That's pretty high, right? So 90% chance that this patient is going to be having a symptom or a bleed is 90%. Whereas the same story in a 70-year-old or a 76-year-old, what will be it? So 96 minus 76 is 30%. It's pretty low. So that's one way of dealing with. I mean, but again, this is it also depends on other factors too. But this is a general number we give it. But then on top of it, there are certain factors which could give much higher risk of bleeding. For example, if this patient has weak points in the brain AVM, that risk is higher. Or if there is the veins are going into the deeper part of the vein, the deeper venous system, the risk is higher. Or AVM is smaller. In fact, that's kind of a controversy. I mean, it's kind of a, what do you say? Typically we say anything larger is more risk, right? But in AVM, the smaller AVMs actually have much more risk for bleeding than larger AVM. That's one of the reason is that because all these things depends on the pressure difference, right? The pressure gradient. When you have a larger AVM, the arteries have a much more larger space to dissipate its pressure. Whereas when you have a smaller AVM, your pressure head is just getting um, spread in a smaller area of the brain. So that's why sometimes if you have a larger AVM, those patients typically doesn't need any treatment. Some I know because they have less chance of bleeding, whereas a smaller AVMs actually have much more chance of bleeding. Yes.
Now, there's some things that patients have under their control to help decrease the risk of complications of the AVM. How big is a blood pressure and smoking play a role into AVMs?
Yeah, I think AVM, as you said, it's a different pathology compared to a brain aneurysms or even a stroke patients. And typically, they are younger patients, they are healthier. Obviously, all those things can contribute to your problem. You're smoking because smoking is a vasculopathic insult to the any blood vessels, right? It could be affecting your heart, it could be affecting your leg vessels, it could be affecting your brain vessels. And then obviously the same thing, high blood pressure is an issue. In fact, I'm glad that you asked about it. In fact, there is a small population of young patient comes to us with bleed, with AVM, who take street drugs, like the drugs which like cocaine or amphetamine, those medications. In fact, they are sympathomimetic drugs. They artificially increase your blood pressure, right? So younger patients come with bleed in the brain after after they took some medication, some drugs outside. They had an AVM which never bled, but then now because your pressure is super high, it bled. So that's another risk you have to. I mean, in our area we see that often. Actually, it's not.
It's unfortunate, but one of the biggest risks for any type of strokes in younger people are drugs, and so right. It's very unfortunate.
Right.
And so Mark had a question here with his AVM. He was told that when he had his seizure, it was due to the disruption of the blood flow. Does that sound correct, or?
Yeah, so the seizure is not because AVMs are the malformation. It's a disease of the blood vessels, right? So the seizure comes from the brain. So why you should have an AVM cause seizure? Because you are talking about two different things. Brain. There's no brain real problems there, but it is because the AVMs are dysplastic abnormal blood vessels. So there is a lot of theories about seizure phenomena in AVM. So one thing is that because of the change in the blood circulation that around surrounding tissue, that's one possibility. Other things that there is a small tissue of the brain which could be dysplastic with the developmental anomaly, whatever you started having. So that could be not healthy enough, and that probably causing seizures.
Yeah, I favor the second.
Right. Yeah. That's what I mean. At the same time, the response to surgery is really high with seizure treatment. Very rare situations your patients will continue to have seizures, and often the seizure will respond to your surgery or um, yeah, but yeah, and in fact, surgery is much better. Um, have a much better response for seizure control versus any other treatment like radiation or even yeah, yes.
Yeah, so Mark ended up having complications of epilepsy.
Yeah. So I think yeah.
And he had uncontrolled seizures for quite some time. How many years when was your last seizure? How many years ago? 5 years ago. So that's about the time I started seeing Mark, who adjusted his seizure medications.
Yeah, so Mark's case was a little bit different in the sense that there was some issues with this surgery, right? So that could have caused a secondary brain injury, which could have just triggered another seizure. That's not uncommon. I mean, he probably has some scar tissue from the initial surgery.
Exactly.
And infection and all the things could have just triggered it. But generally, by and large, seizures are better. Really, this is one of the areas the seizure surgery will respond really well with surgical treatment. Yes.
Yeah. So in Mark's case, for example, when I saw him, he was still having refractory seizures, or we call localization related epilepsy. That's refractory. And we did medication adjustments, but if he didn't respond, we would probably send him in for a video EEG monitoring to see if we could do a second surgery to remove some of that scarring. Now, if we don't have to put someone under surgery again, then obviously that's better, especially if they're. But that would, I don't think I ever explained that to Mark. That was the next step in line for him. But those are my thought processes when we're going through these things. Of the tools that we have in our toolbox when it comes to trying to control epilepsy, especially if we have a focal source of where that seizure is coming from.
Yeah. So when I talk to a patient with seizures, there I will, especially when I give the options of treatment. So no treatment is an option, as I talked about before, but the chance of getting a refractory stage of seizure it's there, and obviously surgery is an option. This is one area I would say surgery is if the patient can get this surgery safely, surgery is the best option available for AVM. And in my mind, AVM is a surgical disease. But there are certain situations we can't do surgery because of the location and the complexity of the AVM. In that case, um, um, we tend to treat this patient with radiation treatments, right? Again, there are two ways of radiation treatment. There are conventional radiation therapy treatment where you do multiple sessions of treatment, which is typically given for a larger AVM, where because we can't, And the second option, which is more popular and more effective, is a stereotactic radio surgery. It's kind of a misnomer. We say radio surgery. It's not a surgical procedure, but it's a one-time treatment where you focus the radiation towards the AVM nidus with a high dose, which is which is not given for a normal tissue, which just for the AVM. And then the radiation, because of the high dose, the AVM tend to close off over a period of time. It takes about months to years to close off by thickening of the blood vessels and then slowly sclerosing and then stopping it. But what's the problem there? There are a couple of things we have to talk about it. One, obviously there is no surgery involved. This is an outpatient treatment. There is no surgical risk, right? But there are certain disadvantages with that treatment too. One of the major disadvantages is radiation treatment. Radiation has side effects. You don't see it right away, but it could happen few years down the line, especially when you are a younger patient, your brain is developing, there is radiation, and the amount of radiation you give is pretty high, and that could have a radiation effect. That's major things I talk about it. And second thing is that this is not, even though it's a one-time treatment, the effect is not immediate. It takes months, years, typically almost like 18 months to 2 years of after the treatment. So what does that mean? So that means your AVM is active next 24 months. So what's my risk of bleeding in the next 24 hours, right? So there is a risk. And especially if you had a prior risk, that's prior bleed, then your risk is much higher. So that's why, if this AVM is safely treatable with surgery, I would say, sometimes that's the best way to go with, because especially if you had a prior bleed, we don't want to wait for another second bleed happening in that next 24 months. So those are the two things I would say. And the third aspect, as Dr. Oli was talking about, the seizures. Seizures are not well controlled with radiation treatment alone. The AVM may go away, but your seizure may not go away, because as he's talked about, the seizures coming from the abnormal dysplastic brain tissue, which is, we are not treating it. They are still there, and they're not going to go away, and the seizure continues to be there. So you may end up being on medication for longer time. And even if you have surgery or even radiation, we tend to treat those patients, we continue the medications longer. We don't stop it. I mean, maybe Dr. Oliver can address that issue. We typically keep them on at least for 2 years to make sure there's no further seizures, and then slowly taper it and stop. Yes.
Yeah, so there's a lot of surveillance that goes along with post-procedural or any type of brain injury and someone has a seizure. One is monitoring, doing EEGs, seeing what the risks are, making sure that they're having any focal or what we call auras, very simple seizures, and that kind of dictates the avenue of, is this person at a low risk that we could start tapering off seizure medications, or we have to continue seizure medications. Obviously, the type of seizure medication also plays a role into the management as well, because they are a focal seizure. We want to make sure we've got them on the right seizure medications based on their profile, meaning that if they have any other medical problems such as depression, etc. So sometimes you have to look at all the different factors when it comes to their seizure management. Sometimes I have a patient, for example, that they might have had a seizure for a long time ago and was very controlled on one of the medications that have dual effects, meaning that they have effects both for depression and for seizure management. And the patient's feeling the best that they've ever felt. Well, I'm probably never going to take them off that medication because they feel good. And we could start decreasing it, but if their feeling starts changing or if there's any signs of seizures, then we're going to keep them on that. So there's not a specific rule, but 2 years, we feel a lot more comfortable when someone's seizure free for 2 years. Obviously, there's the risk too when I talk to patients is, we're going to start taking you off seizures, you might have a seizure, and then it might affect your lifestyle, affect your driving, etc. So a lot of patients at the end of the day, they're like, I'm seizure free right now, I am good, don't touch my seizure medications. I need to drive, I'm active, I need it for work, I need it for my family, etc. When I'm on vacation for a long period of time, then we could start discussing some of these changes. But all those social dynamics come into play. So it's it's really a personal decision, and all those factors have to be discussed, because I could say, well, the textbook says X, Y, and Z, but if you never discuss all those social aspects when it comes to the management, it's really not treating the person.
Right.
It's truly not treating the person. And so one thing what the textbook says, and one thing is what the patient's actually going through in their life. And that's so important sometimes with the management.
So there are some questions. I don't know, are we supposed to answer those questions? Can you
Oh, am I solo now? So let me see some of these questions real quick. So they asked about Mark. He hasn't had a seizure for 5 years. There's a question regarding, are we seeing more ischemic strokes right now? That might be referring more to the uptake in COVID cases that are ongoing right now. And there is a higher incidence of stroke on COVID. The overall incidence for stroke is pretty much equivocal. It's about the same. It hasn't changed dramatically. And then overall, over the last 5 years, we've actually done a better job when it comes to the death rate when it comes to stroke. And I obviously, anybody that's ever had a stroke or had any type of brain trauma, hemorrhage, etc., any type of brain injury, the big factoid on this is the recovery, is the rehabilitation, is the mindset, and all those different factors that really makes it a comprehensive. So now when we talk about these things, we're also planning for recovery. What is this person going to need for when that AVM comes out? They have a slightly more slurred speech. They're going to need speech therapy. They're going to need all those recovery aspects, etc. And so that's where the real work comes in, right? That's the hardest part, that mindset too, and having a good support cast and support group around you. It seems like I'm the lone soldier at the end of this interview, but I just want to thank everyone here. If anybody has any other questions, we got Dr. Pillai back on.
I got disconnected.
Okay. And so I was just going over some of the questions. Any other questions that we did not? Mark also had a question regarding migraines on his AVM as well. And so sometimes when it comes to hemorrhages and post-operations and any type of brain injuries, there's definitely some type of irritation that happens within sometimes the meninges or any type of pain centers within the brain that causes focal pain. And that's sometimes very difficult to treat and try to localize where that pain's coming from and what's the best treatment course for it.
Yeah, I think Mark's case, I would say, I would put it as a traumatic brain injury kind of category too, just not the AVM, right? So the things you talked about, I think you have to put it in that perspective. So it's just not the AVM. So I can't extrapolate your symptoms with the AVM patient because yours was all the things it happened with you, it contributes to your symptoms. So it can't, and even your seizure symptomatology and your post-surgical headache and things like that. Yeah. Okay. I don't know if you talked about endovascular treatment, but that's something, again, endovascular treatment, we just do it for pre-surgical or a pre-radiation treatment. They're not definitive treatment. So they're just part of your treatment that we can, that's something, that's completely different. Yeah.
Yeah. We did not mute Mark, so it wasn't us doing it.
What is that?
I said we didn't mute Mark, that's for sure. So we're missing Mark as the pilot here. But is there anything else
Anything else you need to talk about?
There's one person that wrote that they were diagnosed having epilepsy since their stroke.
Yeah.
And so obviously that can be a complication of stroke or during stroke. And obviously it comes in within the diagnosis.
Yeah.
And, you know, one of the common reasons why people in their geriatric population have the onset of epilepsy is because they had a history of stroke, because of that scarring tissue formation in that area, and causes a disruption in that cortex. So, yeah, that can occur as well. And so, when it comes to epilepsy, there's always something new out there when it comes to medications, when it comes to treatments, surgeries, laser surgeries, and so it's forever evolving. So it's one of those things that's very promising for our patients when it comes to controlling their seizures as well.
So there is a question about hemorrhagic stroke caused by sinus disease. I didn't understand that question, but are we talking about venous sinus disease or is it a sinusitis problem?
Was it a venous thrombosis?
Mr. Jerry Wald is asking, I was told my hemorrhagic stroke was caused by my sinus disease. What's your thoughts, doctor? So, I mean, I don't know. I mean, if there are two issues here. Sinus, when you say sinus disease, there are venous sinuses in the brain, which is basically the outflow of your vein, the blood back into your heart. So those veins, if they get blocked, that can build up pressure inside your brain, which can cause, we call a venous infarct in the brain, and which can bleed, which can cause hemorrhagic stroke. So it's a other way of, it's not arterial, that's not from the artery, which is the other side of the spectrum, where you have the venous outflow obstruction and sinus block and hemorrhage. That's a very devastating disease, often with bad outcomes. But sometimes we may have to, majority of those cases we treat with like anticoagulation treatment to prevent propagation of the thrombus. In some situations you may do endovascular treatment where you can go in and clean up that sinus and remove that clot from the vein to restore the blood flow.
Yeah, it sounds confusing because when we think of sinuses, we think of this, right? But this sinus, we're actually talking about the vein, the venous system of our brain. And that's obviously very delicate, very, very delicate. And so people have it for different reasons. We see it after a traumatic brain injury. Someone has a concussion or a hit. People that have dehydrations or have what we call hypercoagulable state, where their blood is thicker because of an underlying condition, etc.
Which is Serena Wagner, just wondering if a person doesn't have their flap after hemorrhagic stroke, 8 years post-stroke, would you suggest replacement now? Yes, what's the option today? Yeah, I mean, we didn't talk about hemorrhagic, the ischemic stroke management. When the stroke happens, there is a major part of your brain is having no blood supply. So when that happens, one of the complications is the brain can swell. We call a malignant intracranial pressure building up. So that can cause severe pressure. And remember, the skull is like a closed space. And if your pressure goes up, the pressure can significantly affect your brain, the rest of the brain. So in some situations, the neurosurgeons can help in stroke cases where they can take a part of the bone, remove it so that the brain has more space to swell. So what are the options? We typically, those bone flap, we keep it in a freezer, or sometimes in situation we may even put it in the abdomen, on the abdominal wall, and we go back once the brain swelling goes down. It typically about 6 to 8 weeks. You go back and open up the scalp and then put that bone back. That's what we typically do. If you don't do it for more, within that period, there is a couple of issues because the scar tissue, remember there is no bone there, and the scalp is right stuck to your brain. The more you wait, there's a less chance that we can safely remove that scalp off the brain. I would suggest to do it sooner if we can. And unfortunately, sometimes we see patients come back really late, maybe a year, 2 years later, without a bone, having a helmet, which is really a sad thing. And it's really difficult to do treatment those patients because first of all, we can't put the same bone because bone is not healthy enough. Then we have to put an artificial stuff, which can be risk for infection. And then more other thing is that separating the scalp from the brain can be problematic. It can even hurt the brain because the brain is all stuck to your scar tissue, and then going back, it's not safe. But if possible, I mean, we should, because then you protect your brain with a good coverage so that you don't have to walk around with a helmet. Yes.
And Jerry asked, does he need to see an ENT doctor?
So that's what I'm asking. If it is sinusitis you're talking about, yes, you have to see an ENT. But if you say sinus problem in the vein, because in the brain, that's a whole different thing. That has to be seen by a neurologist and a hematologist. Because if the sinus problem was happening, the sinus block, we need to know whether this is it's a recurring issue. Is it something's going to come back again? That's why you need to see an hematologist. But that's why it's two different things. I'm confused. Maybe he's talking about the ENT sinus problem. If it is a sinus problem in the nose, then we have to see an ENT doctor for sure.
Yeah, it could be quite complicated when we talk about sinuses because
right.
We have our cavernous sinuses back here that different things could happen as well. So it's very complicated. So sometimes when we're discussing different topics like sinus venous thrombosis, for example, that's here in the cranium.
I mean, there is a one possibility I can think. The sinus infection can spread infection to the veins in the brain, which can cause same problem, which can also cause a hemorrhagic stroke. So that could be another issue which is talking about. But we may need more information about that before we just say something about it. Yeah.
Right. I agree. Again, Mark, I just want to thank you for putting us here all together. Dr. Pillai, with your world-renowned expertise in neurosurgery, one of my go-to neurosurgeons, that within a helicopter flight has saved many lives. So I just want to thank Dr. Pillai. Thank you for everything that you do. I just want to end as Mark does with a special prayer. Thank you, Lord, for today and allowing me to discuss different topics in medicine with Mark and Dr. Pillai and sharing it with his audience. And hopefully this serves as a platform to help better understand both the patient perspective and the physician perspective to help better guide the care of our patients. In the Lord's name. Thank you, Mark.